Thank you, Carla, and I want to thank Phillips for inviting me to give this presentation to you. I hope that it's very helpful for all our attendees. We have just recently updated the SRU guidelines, which change interpretation of the liver elastography a little bit, so I think you may find this a very interesting talk. So we're going to start with liver elastography, and I'd like to review the protocol for performing liver elastography because it's very critical to get good results, discuss interpretation of liver elastography, and review best practices based on the Society of Radiologists guidelines, and we'll discuss the limitations of the technique and review some artifacts. So chronic liver disease is a substantial worldwide problem. Its major consequence is increasing deposition of fibrous tissue, leading to the development of cirrhosis, and its complications of portal hypertension, hepatic insufficiency, and hepatocellular carcinoma. The stage of liver fibrosis is important to determine prognosis, surveillance, and prioritization for treatment. Now we know that there's the potential for reversibility. And the process of fibrosis is dynamic, and regression of fibrosis is now possible if we treat the underlying conditions appropriately. And previously, the only method of staging the degree of fibrosis was liver biopsy. There are many different causes of chronic liver disease worldwide. The viral hepatitis C in the West and hepatitis B in the East remains a major risk factor. Although the incidence of compensated advanced chronic liver disease, which we'll discuss shortly, may be lower because of the advent of interferon-free, highly effective antiviral therapies. And the staging of liver fibrosis is still necessary to treat because patients with compensated advanced chronic liver disease required continued surveillance for hepatocellular carcinoma and or varices after the clearance of the virus. A rising cause of chronic liver disease worldwide is non-alcoholic fatty liver disease, currently the most common liver disease in the United States, with a worldwide prevalence of 25% by imaging estimations. NAFLD may be either simple steatosis to non-alcoholic steatohepatitis or NASH that may proceed to fibrosis and cirrhosis with all the complications of cirrhosis. Although there is no specific treatment for NASH, lifestyle modifications have been associated with a decrease in the complications, including portal hypertension, and the identification of compensated advanced chronic liver disease allows for screening surveillance of varices and hepatocellular carcinoma. Therefore, avoiding a biopsy, and we can exclude the diagnosis of compensated advanced chronic liver disease in this patient, as this is of utmost importance. And we know that liver biopsy has been used in the past as the reference standard, but it's really a very inaccurate method. It is the reference standard for fibrosis assessment, but it also stages classification and grading steatosis, necrosis, and inflammatory activity, which we cannot yet do with ultrasound, although I think that will be coming in the next year or two. It's invasive with severe complications in up to 1%. It represents 1/50,000 of the liver volume, and there's considerable inter-observer variability, which is the key point to remember. So if we look at pathology studies, the pathologists disagree quite often. They only agree 40 to 90% of the time. So when we try to use elastography to correlate with biopsy, we have to deal with a pathologist not being able to give a consistent MEDAVAR score. So cirrhosis consists of at least two distinct stages. We have our chronic liver disease that has progressing fibrosis, and then we reach compensated cirrhosis to decompensated cirrhosis and then to that. So decompensated cirrhosis is a very easy clinical diagnosis. These are the patients that present with variceal hemorrhage, ascites, encephalopathy, and jaundice. Their mean survival is approximately 2 years. Compensated cirrhosis is not an easy diagnosis clinically. These patients do not present with all the complications that we see with decompensated cirrhosis. and their mean survival is greater than 12 years. So you can see that if we can find these patients at a compensated cirrhosis or earlier stage and get them treated so they do not progress to decompensated cirrhosis, we can significantly increase their survival. And in compensated cirrhosis, there's also varices make a difference in the mortality rate. If they do not have varices, they have a 1% per year mortality rate. If they have varices, that triples to 3% per year. And again, I've been using this word, compensated advanced chronic liver disease. This is a new term that describes patients at risk for the complications of chronic liver disease, portal hypertension, risk of hepatocellular carcinoma, and varices. This corresponds to Medivir scores F3 and F4, and this is now what is most clinically relevant classification of chronic liver disease. So almost all of the guidelines now recommend us not using Medivir scores, but evaluating the patient based on the probability of them having compensated advanced chronic liver disease. Let's just go through the measurements, how to do the measurements, because it's very critical. You have to follow a very strict protocol to get accurate measurements. So one, the patient should fast for at least 4 hours before the examination. And this is because as we eat, we have increased blood flow to the gut, increased blood flow through the portal vein, and the liver actually becomes stiffer. The measurement should be taken at the intercostal space in the supine or slight lateral decubitus position with the right arm in extension. So the arm should be way above the head. And this is to open up the rib space so you have a better acoustical window, because we do use B-mode imaging to track the shear waves. The RF pulse generates the shear waves, but it's really our B-mode imaging that tracks and estimates the speed of the shear waves. So we must have a good B-mode image to get accurate shear wave speeds. The measurement should be taken in neutral breathing during a breath hold. If we take a really deep breath in or do a Valsalva, we increase our right heart pressure, and that's transmitted through the superior vena cava to the hepatic veins, and it actually increases the stiffness of the liver. So we want to try to do this in a neutral breathing position. Measurement should be taken at least 15 to 20 millimeters below the liver capsule, particularly in point shear wave, and we'll discuss this at length a little bit later. And this is because we see reverberation artifact in that first 1.5 to 2 centimeters, which gives us markedly higher readings than the normal liver. For the 2D shear wave, the ROI can be positioned closer to the liver capsule because we can see the reverberation artifact in the color map, and therefore we can avoid it, and we can position our ROI box in an area where we don't have that artifact. We can report the results either in meters per second or kilopascals. I think of this as either centimeters versus inches. So it's really very easy to convert one to the other. And actually the Philips system will give you both in the final report. In most systems, the maximum RF push pulse is at about 4 to 4.5 centimeters from the transducer. So this is the area we have the most RF strength, which gives us the best shear waves. So this is really the optimal location to obtain the best measurements. In most systems, the RF push will allow you to go to 8 centimeters, but usually, particularly in a very steatotic or cirrhotic liver, after about 6 centimeters, the RF pulse is attenuated such that the shear waves are very small, and it's very hard to get accurate measurements. Major potential confounding factors include severe liver inflammation, indicated by AST and or ALT elevation. And if it's greater than 5 times the upper limits of normal, we really can really overestimate the degree of liver fibrosis. Obstructive cholecystitis, liver congestion, acute hepatitis, and infiltrative liver diseases all lead to overestimation of the stage of fibrosis. 10 measurements should be obtained with point shear wave, and the final result should be expressed as the median together with the interquartile range divided by the median. And we'll talk about this. This is really the best way to evaluate if we have quality data. If less than 10 measurements with point shear wave are obtained, and it always should be above 5, but sometimes it may be difficult in a difficult patient, always use that IQR over median, and it should be within the recommended range to be accurate to have good measurements. For 2D shear wave elastography, 5 measurements should be obtained when the manufacturer's quality criteria are available, and the final result should be expressed as the median together with the IQR over median. And this interquartile range over median, IQR over median, should be less than 30% of the 10 measurements in point shear wave or the 5 measurements in 2D shear wave, and that is if you're doing the measurements in kilopascals. If you're doing the measurements in meters per second, that has to be less than 15% because the conversion from kilopascals to meters per second is not linear. And again, adequate B mode liver imaging is a prerequisite for point shear wave and 2D shear wave, as the shear waves are really tracked by B mode imaging, not the RFE pulse. So just some brief pictures to show you what you should be doing. The transducer should be parallel to the rib space and perpendicular to the liver capsule. You do not want to place the probe across the ribs. You do not want to angle the probe to the liver capsule. You do not want to do any substernal scanning. You do not want to angle to evaluate the left lobe of the liver. And the left lobe of the liver is very difficult to get accurate measurements because we always have motion in the left lobe of the liver from the pulsations of the heart. We want to avoid imaging at depth. And again, I mentioned that the best spot to probably do measurements is around 4 to 4.5 centimeters from the transducer, but we still must maintain that 1.5 to 2 centimeters from the liver capsule. As we go deeper, we weaken the RFE pulse because of attenuation. The shear waves are smaller, it's harder to track them, and we may have more error in our measurement. Most systems will allow you to actually move the box down to 8 centimeters, and that may work in a very normal looking liver, but as the patient has a high BMI or a steatotic liver, usually around 6 centimeters, we start to have problems, and you may notice that you can't get a measurement, and that's because the shear waves are so small, because the RFE pulse has been attenuated and is no longer generating shear waves adequate enough for a measurement. We want to avoid imaging at vessels because they have a different stiffness value, and also the shear waves will bounce off of them and give a reverberation pattern and give you abnormal values around 5 millimeters from the vessels. And this is a very important thing in point shear wave, but because you can't see where the artifact is. In 2D shear wave now, we have the quality map, which will allow us to see where the artifacts are and avoid them when we place our ROI. Again, we do not want to angle the box to the liver capsule because, again, we have refraction of the RFE pulse and we will get inaccurate measurements. And again, we get this reverberation artifact that I'll show you in a slide a little bit later, and we want to avoid that. And again, in point shear wave, we don't know where that artifact is, so we must place the box at least 1.5 centimeters, even 2 centimeters below the liver capsule to avoid that artifact. When we're looking at 2D in that velocity map, we can usually see where the artifact is and therefore not put our ROI in that. And occasionally, if you have a patient with very steatotic liver or very high BMI or a lot of subcutaneous fat and the liver is somewhat deep, in 2D you can move that box up towards the liver capsule and you can hope that you have very little reverberation artifact. That will give you a little bit better value to calculate the estimate of the shear wave speed in those difficult patients. Factors that affect measurements. The strength of the RFE pulse is what I use to say this is what we really have to have. The stronger the RFE pulse, the better the shear waves, the easier we can measure with B mode, the more accurate our measurements are going to be. And again, the RFE pulse is attenuated as it traverses tissue. Therefore, measure taken at greater depth have less signal to noise. And although the system presently has a limitation of 8 centimeters, in a difficult patient, maybe after 6 centimeters, you just may not have enough energy left to generate shear waves that you'll be able to get a good estimate of their speed. And again, this attenuation is greater with a stiffer liver, so patients with advanced cirrhosis measurements can be more variable. And I believe that the RF pulse is refracted from the liver capsule if it's at an angle. So you must maintain the transducer parallel to the liver capsule. I think particularly when you're starting, one of the hardest factors is breathing. We know that measurements taking a patient or a scanner motion are inaccurate. The shear waves are only generated over a few millimeters, so very small motion can cause erroneous measurements. So we want to control the breathing while performing these measurements because it is critical to get accurate measurements. And we should be taking the measurements in a neutral position, so not inspiration or expiration. And again, this is because we change the right heart pressure, and that is transmitted to the liver. So when we do a Valsalva, the liver actually becomes stiffer. So we usually practice with the patient before we start taking measurements, because usually when we say stop breathing, they take in a deep breath in and do a Valsalva. So we make sure before we start doing our measurements that we practice with the patient so they understand when we say stop breathing, they just stop breathing. There is an advantage to using the real-time 2D shear wave and Elastography with this, because you have a real-time B mode image and you can actually see how the liver is moving and making sure that the patient is breathing in the right position to do your measurements. And with the modern equipment now, we only need to have them hold their breath for a few seconds. So it's really not very difficult for the vast majority of patients to hold their breath. This is actually me, taken within a minute of each other. You can see I have a nice steatotic liver. But in this upper box, you can see that I have a normal liver with a shear wave speed of 0.5 meters per second. But when I did the best Valsalva I could do, I actually made it look like I was cirrhotic with a mean speed of 4.8 meters per second. So breathing can really change measurements. So it's very important that you all use the same protocol in your lab and you all do the same thing, because this can cause variability between measurements between your sonographers or sonologists doing the exam. So let's just briefly go over how we should perform the exam. So again, we're going to use that intercostal approach to the right lobe of the liver. I like to say we want to optimize the B mode image, find the best acoustical window. That usually means you're going to be taking measurements in segments 5, 7, or 8. You want to avoid all the shadowing if possible, and not just complete shadowing where you have a real black shadowing, but the image and the B mode should be relatively uniform in brightness throughout the image. If the image is not uniformly bright, you probably have some refractive shadowing that causes the ultrasound beam to be bent, and again, can give you inaccurate measurements. Again, measurements should be taken in a breath hold in a neutral breathing position. Measurements should be taken in the right lobe of the liver, because we know that measurements in the left lobe of the liver are unreliable. We want to avoid that first 1.5 to 2 centimeters from the liver capsule. We try to take this relatively the same. So again, for reproducibility, if a patient comes back, and reproducibility between people doing it in your lab, if you all come up with taking it about 2 centimeters below the liver capsule, that kind of standardizes where you're doing the measurements. We're going to talk about why that's important in a future slide. We're going to avoid large blood vessels and bile ducts. And again, in point shear wave, this is very critical. In 2D shear wave, you will see the artifacts and you'll be able to avoid them. The RF pulse should be perpendicular to the liver capsule. So this is our protocol. You can see, and I think I can do a little laser pen here, that here is our transducer. We're going to have the liver capsule parallel to the transducer. We don't want the liver capsule angled like this. And usually when you find your window, it's just a few tiny motions of your wrist to get the capsule so it's nice and perpendicular. And then we're going to place the box, as here in point shear wave, or the larger field of view box in 2D shear wave parallel to that. So we're going to have 3 parallel lines when we do this. And again, we try to standardize the depth we take things, and we like to put the box at 1.5 to 2 centimeters below the liver capsule if we can. Factors that affect the measurement reproducibility: excessive motion, either by the patient or the sonographer. Again, our measurements now are done in relatively a few seconds, so the patient does not have to hold the breath as long as they did 5 years ago. And most patients are going to be able to do this. When we talk about 2D shear wave, we'll show you some tricks that even if they can't hold their breath, we can show you how to properly do this and get good measurements. Tissue attenuation: subcutaneous fat and a stiff liver, again, are going to attenuate the RFE pulse, give us weaker shear waves, which are harder to measure and can increase the variability in our measurements. And these are the patients that it becomes very difficult sometimes to do. Poor scanning window: again, we want no shadowing. That B mode image of the liver should be the uniform and attenuate signal or brightness of the liver throughout. There should be no areas that are a little bit darker, because that's telling you there is some partial shadowing. The depth of the ROI is very critical, and we'll talk about that a little bit more at length shortly. And we want to, again, avoid blood vessels and other interfaces. And remember, this is a 3D process, not 2D process. So you have to remember that vessels that are out of the plane may also show up. So again, this is another advantage of the 2D shear wave, because it has a quality map that will show you where these are at. In point shear wave, we don't know where they're at. We try to avoid the vessels we know that we can see on the image. And this is why we have you do twice as many measurements in point shear wave, because you don't know if you're taking the measurements in an area of artifact or not. In 2D shear wave, we're taking less because we know where the artifacts are, or most of the artifacts are, and can avoid them. Other confounding factors that are patient dependent include congestive heart failure. You have to remember that we do not measure liver fibrosis, we measure liver stiffness. And liver stiffness is a combination of fibrosis, congestion, and inflammation. So in congestive heart failure, or even in renal failure, people that have increased right heart pressure, a pediatric patient with a Fontan's procedure, the right heart pressures are going to be elevated. That pressure is going to be transmitted through the inferior vena cava and the hepatic veins, and it will make the liver stiffer. So if you use cutoff tables, you're always going to overestimate the degree of fibrosis. Exacerbations of acute hepatitis with associated transaminase elevations, again, are going to increase the liver stiffness. And if you use cutoff tables, you'll overestimate the degree of fibrosis. And again, I think a critical thing to remember here is if those liver enzymes are greater than 5 times the upper limits of normal, you have to really be aware that the calculating the degree of fibrosis is probably going to be inaccurate. Again, when we ingest food, we have increased blood flow to the gut, increased blood flow through the portal vein, and the liver becomes stiffer. And in general, we like to wait 4 hours after a patient eats to do these measurements, because then in the vast majority of patients, the liver stiffness goes back to normal. In the literature, steatosis has reports that say that it does, and others that say that it doesn't affect the liver stiffness values. I don't believe that steatosis in itself affects the liver values as we're doing things today, but it is making it very, very difficult to get accurate measurements because of the weakening of the RFE pulse. So I think we get variable results, not because the steatosis changes the shear wave speed of the liver, but because we just can't get very accurate measurements of the shear wave. In the near future, we're going to be doing something called dispersion. It's not available yet on the system, where we're going to actually vary the RFE frequency, and that change in that frequency will allow us to do some new features, and that will be affected by steatosis, and that may be one way that we can actually quantify steatosis in the near future. Other things that will artificially elevate stiffness measurements: extrahepatic cholecystasis, the use of beta blockers, which can change the portal pressures, and as I showed you in myself, doing a Valsalva maneuver. So where should we take the measurements? In the same location or various locations? So we know that this is a diffuse process. However, the best accuracy in liver stiffness value is from multiple measurements in the same location. And what I have here on the right is something called a bias table. There was a organization or committee, if you will, that is RSNA, some clinicians, the FDA, and some research scientists and all of the vendors. And what we developed some liver phantoms that had stiffness values of 1.1, 2.3, and 2.9 meters per second. And we did serial measurements on all of the vendors we had at that time at 3 centimeters, 4.5 centimeters, and 6 centimeters. And this is from the first round that we did this. And the numbers in these little boxes tell you how this system did. So if we look at this box of 0, that's telling us at 2.9 meters per second at a 4.5 centimeter depth, this system actually got a perfect measurement. However, in the 1.1 centimeter stiffness, it underestimated it by 15%. And you'll notice that the measurements go almost up to 20%. And again, you'll notice the deeper we go, the more error in the measurements. So these measurements were given back to the vendors. They were able to see where they were having problems, and they've readjusted the system with appropriate factors so that these numbers are now usually less than 10% in the last round. So the variability that we see in the system, depending on where you take a measurement in the liver, can be up to 10%. And you can see that we would get more consistent results by taking the same measurements in the same location. And again, it's really depth that's important here. So how many measurements should we take? In point shear wave, the literature suggests 10. Now, you shouldn't go and delete the highest and lowest number. You shouldn't have to delete measurements that are greater or less than the standard deviation from the mean. Because if you're doing things right, you should have numbers that are very close to each other. Obviously, if you know the patient took a deep breath, you moved, or something was wrong, don't put that measurement in the calculation package. But in general, you should be able to do this without looking at the numbers and deleting ones you don't like. A couple features that we really think you should follow. So one, greater than 60% of the measurements are good measurements. And by that, I mean that we get a measurement. So again, if you were taking a measurement very deep and you didn't have enough energy, you would not get a measurement in point shear wave. You would get 0, 0, 0. Whereas in 2D, the color map would not show any color. So that's telling you that there were no shear waves that were able to be measured. So if greater than 60% or less than 60% are not good, then you should assume that that patient is a patient you really can't do good measurements. So if you did 10 measurements and 5 of them you got 0, 0, 0, that's basically telling you that that patient is someone, no matter how many measurements you take, you're not going to get accurate measurements. And again, we like to use this interquartile range over medium, and the system will calculate that for you in the report page. Less than 0.3 for kilopascals and less than 0.15 for meters per section tells you that your data is all very close to each other and that you most likely have a very good data set. And I like to use this because I monitor our sonographers' quality. So obviously you can't do this based on one measurement, but over time I can watch our sonographers. And we have some that routinely get between 0.1 and 0.2 in kilopascals, and other usually between 0.2 and 0.3 in kilopascals. And I can see the experience in our lab. And overall, since we've been doing this for several years, I can see that the IQR over median continues to drop as we gain experience and the machines get better and the training of our technologists is better. Now for 2D shear wave, we're going to show you what that quality map does. It allows you to know where the artifacts are. So here you're going to put your ROI in an area that you know most likely does not have an artifact. So we're only requiring you to take 5. But again, 60% of the measurements have to be good measurements, and we're still going to use that IQR over median of less than 30% for kilopascals and less than 15% 4 meters per second. So on the Phillips system, we have Elastpq and Elastq. So Elastpq is a point shear wave technique, and it provides a stiffness value in an approximately 1 centimeter box. Elastq imaging is a 2D real-time shear wave elastography. It provides stiffness values over a large field of view, and it's color-coded for easy review. ROIs can then be selected in that large field of view to determine stiffness values. And you can use larger ROIs for averaging over a larger area of the liver with Elastq, which sometimes is helpful, particularly in the medium, like between 9 and 12 kilopascals, where the color may be a little mosaic. So there are some real advantages to Elastq, the 2D shear wave, versus the Elastpq, the point shear wave. So Elastq, 2D shear wave, is real-time on the Phillips system, so you have a real-time B-mode imaging that you're watching as you're collecting data. So now you can watch to see how the liver is moving. Even when you tell the patient to hold their breath, you can actually see if they really did stop breathing, so you can confirm that there's no motion. In point shear wave, you don't have a real-time B-mode image, so you're relying that the patient is going to do this by themselves, so you have no way of checking. We can take multiple measurements from that large field of view, although I don't recommend that, because if something was done wrong, all the measurements have the same errors. But what you can do is you can increase the ROI box to average over a much larger area of the liver, which isn't really acceptable. And you can also decrease that ROI box if there are a lot of artifacts and you want to avoid taking measurements in an area of the artifacts. The color coding is helpful in assessment of stiffness without having to look at the values. And that quality assessment overlay or confidence map allows for placement of the ROI in an area of high quality. So here are examples. Point shear wave on the left. Again, we have our ROI box. And here in 2D shear wave, we have this larger field of view. And then here we have these dotted circles, which are our ROI box, where we're getting our measurements. And again, on the Phillips system, you can take your measurements on the screen either in kilopascals or in meters per second, but the report page will always give you both for both point shear wave and 2D shear wave. And again, I think what's really the big advantage of the 2D shear wave is we have the quality or confidence map, which looks at the quality of the shear waves and uses a traffic light. Green is go, yellow is caution, red is stop, to tell you where the good data or bad data is. So again, if we look at this image, the image on the right is the velocity map. It color codes based on the liver stiffness. The image on the left is the confidence map or quality map, and you can see it goes from a 0 confidence to 100% confidence. And what we really want you to do is do measurements in these green areas. So here you can see where the blood vessel is, and it's much wider that it's red because we've got artifacts surrounding the vessel. These other little areas of low confidence are probably vessels here and here, but there may be vessels just in front of or in back of that are causing artifacts. So this will allow you to look to find that area that's green. So maybe in here or in here, we've got the best area to do our measurements, and that will really improve the quality of our measurements. So this is the protocol we like to use for Elastq, or the 2D shear wave, since it's real time. We do all the things we've talked about: supine or right lateral decubitus position, probe parallel to the liver capsule between the ribs, patient holds their breath, stop breathing, all those things we talked about, placing the ROI about 1.5 centimeters below, whatever, get ready. Best B-mode image. Then when you'd ask the patient to stop breathing and you notice on the B-mode they stop breathing, you start collecting a Sydney clip. And a 6-second Sydney clip is probably adequate. If you have a difficult patient that's having a hard time breathing, you may want to extend that, or a pediatric patient, to 30 seconds, because we're going to be able to cine back and look to see where there's area of no motion. In general, the first few frames will have some artifacts as we need the shear waves to build. So after you have your clip, you can now go through your clip and look to see where the velocity map is stable for at least 3 frames. So that's telling you that you've got very consistent data. And then you're going to look at the quality map of one of those good frames and find an area that's green, high quality. And again, I recommend you only place 1 ROI box in each frames. Phillips states you can do 2. You can do it, but my fear is that you're going to have an error in both of those, and then when you average them in, you've added more error into your measurement. So we do 5 independent cine clips, take 1, the best frame, and 1, the best measurement in each of those 5 frames. So we're taking 5 6-second clips. So we're really only imaging for 30 seconds in the average patient to get our 5 measurements. And I think that's really good. And again, it has a running total of the IQR over median. So you can look at that as you're going to see how well you're doing. So let's talk about interpretation. So the SRU in 2015 gave their recommendations. We recommended not necessarily using the Medivar scores, but doing 2 cutoff values, a value which is low, below which you have a very high probability of being normal or have no significant fibrosis, a cutoff value in the upper limits that shows that above that level, you have advanced fibrosis or cirrhosis. And I think a lot of people worldwide have been using that. And this is a table out of that publication. And what this figure shows is we looked at a large meta-analysis, and what we did was say, what is the probability of a certain shear wave speed? So at 1.3 meters per second, we've got a 2% chance of being F0, a 10% chance of being F4, a 20% chance of being F3, and a 35% chance of being F1 and F2. So you can see that below this low cutoff value, the vast majority of patients are F0 and F1, and above this level of the higher cutoff value, most of the patients are F3 and F4. And in the middle, we've got an overlap of all these. And we just can't separate out a lot of these F1s, F2s, and F3s from each other, no matter which method of elastography we're using. The Bevno conference gave recommendations that were somewhat similar to what the SRU did, a transient elastography less than 10 kPa in the absence of other known clinical signs rules out compensated advanced chronic liver disease. Values between 10 and 15 kilopascals are suggestive of compensated advanced chronic liver disease, but need further test for confirmation. Values greater than 15 kilopascals are highly suggestive of compensated advanced chronic liver disease, and values greater than 20 to 25 kilopascals rule in clinically significant portal hypertension. The WFM guidelines kind of modified that a little bit in 2018. 5 kPa and below is normal. Between 5 and 10 kPa, rule out compensated advanced chronic liver disease. Between 10 and 15, rule in compensated advanced chronic liver disease. Above 15 kilopascals, you have compensated advanced chronic liver disease. And above 20 kilopascal, below 20 kilopascals, you rule out varices needing treatment. So what's happened? We now have excellent treatments for hepatitis C and hepatitis B that are less expensive, and most of the world is just treating these patients regardless of the degree of fibrosis. So in the past, at least in the United States, we were doing a lot of fibrosis scanning to determine the level of fibrosis because patients would not be treated until they reach some level of fibrosis. For the most part, that is no longer happening. Anyone that has hepatitis C is getting treated. Anyone that's getting hepatitis V is put on treatment also. So what's now really important is the diagnosing of compensated chronic liver disease, because that flags to us those patients that are at risk for complications. So the SRU guidelines, which have been are in press in radiology and hopefully will be out in a month or so, these are the new recommendations. Given the large overlap of stiffness values for mild to moderate fibrosis, the SRU continues to recommend a low cutoff value below which there is a high probability of no or mild fibrosis, and recommends a high cutoff value above which there is a high probability of compensated advanced chronic liver disease. Because the overlap of liver stiffness values between Medivar scores is as large, if not larger, then the difference between vendors, separate cutoff values for each vendor are no longer required. The variability between consecutive liver stiffness acquisitions assessed by the means of the interquartile range over median ratio is the most important quality criteria, and when this ratio is greater than 30% in kilopascals or 15% for meters per second, the accuracy of the technique is reduced. Additional quality measures using ElastQ include the stability of the velocity map and the quality measure. These are our recommendations: equal to or less 5 kPa, which is 1.3 meters per second, high probability of being normal. Less than 9 kPa or 1.7 meters per second. In the absence of other known clinical signs, rules out compensated advanced chronic liver disease. If there are known clinical signs, may need further tests for confirmation. Between 9 and 13 kilopascals, suggestive of compensated advanced chronic liver disease, but need further tests for confirmation. Greater than 13 kilopascals rules in compensated advanced chronic liver disease. Greater than 17 kilopascals is suggestive of a clinically significant portal hypertension. You'll notice that we dropped the higher cutoff value to 13 because now we're including more F3s, because again, those Medivore F3 people are also at risk for the complications. So in patients with chronic hepatitis B or chronic hepatitis C successfully treated with antiviral drugs, the cutoff values obtained in viremic patients should not be used because a rapid decline in stiffness values has been observed in these subjects, likely due to the decrease of liver inflammation. When liver cirrhosis is evident by B-mode findings, elastography should not be used to rule out the disease, as a value in the lower range of liver stiffness may only indicate a successful response to the antiviral treatment. Basically, although we treat these people and they may become virus-free, they're still at risk for all the complications. So they all need to be followed. Based on the results of both prospective and retrospective studies with over 1,000 patients, the delta change of liver stiffness over time should be used instead of the absolute value. Thus, each patient becomes his or her own control. So we now follow the patient and see if the values go up or down to decide if they're getting worse or better. For pediatric patients with liver disease or congenital heart disease with Fontan surgery, it is expert opinion that each subject become his or her own control, using the stiffness delta change over time to evaluate the efficacy of the treatment or the progression of the disease. So here's our new SRU table, and again, we left basically the low cutoff value the same. We moved the high cutoff value down from 15 kilopascals to 13 kilopascals, so we include more F3s that are going to be probable to have compensated advanced chronic liver disease. Well, we added this dotted line of 17, above which suggestive of clinically significant portal hypertension, and the second dotted line of 9 kilopascals, which raises our suspicion. So we kind of split that middle area into two, one that has a lower probability of compensated advanced chronic liver disease, and one that has a higher level of possible compensated advanced chronic liver disease. This white dotted line, there are some studies in patients that have NAFLD that they may turn to NASH at around 7 kPa instead of 9 kPa. So we put that in as maybe between 7 and 9 kPa in patients with NAFLD. You may want to screen for NASH. Because there is an approximately 10% variability of measurements within a vendor and between vendors, a clinically significant change should be considered when the delta is greater than 10%. The panel recommends using the same equipment for follow-up studies in patients with chronic viral hepatitis that are successfully treated. The baseline liver stiffness should be that obtained after viral eradication or suppression. Applying this rule, liver stiffness assessment can be suitable for evaluating all clinical conditions leading to an increase in liver stiffness, independent of the disease etiology, including non-fibrotic causes of liver stiffness, such as congenital heart failure. Liver stiffness measurements for a report, you want to mention the vendor, the machine, which probe you're using, the number of measurements, point or shear wave, and give the IQR over median, and then use the new SRU guidelines for how to interpret the results. And again, if you have different equipment in the lab, please try to use the same one, same positioning that you're doing the measurements, the same depth, which is critical to be able to decrease the variability between measurements in the patients. For other etiologies, such as alcoholic hepatitis, primary biliary cirrhosis, Wilson's disease, autoimmune hepatitis, sclerosing cholangitis, drug-induced liver disease, there is insufficient data to make a conclusion. We do think our table does work, but we don't have enough data to say that it does work. Alcoholic liver disease is complicated due to the large amount of inflammation, increasing liver stiffness, making it difficult to assess liver fibrosis. Let's just go briefly, I'm running out of time, on some artifacts. Again, the ElastQ ROI, there's been some changes in the new things, and that quality map, again, really increases our availability to identify artifacts. They've increased the quality of it so that it marks out more artifacts, so you have this, and this improves your interpretation, the stiffness on the velocity map and the robustness of the caliper placement. So again, old release, new release, you can see that we're eliminating more data because we're only now showing the data that is of higher quality. So the new map is telling you where the best quality data is. So yes, you don't have as much color in the box, but that's a good thing because now this is telling you where you have very high confidence of having a good measurement. In the past, this was our reverberation artifact. This green and red was the artifact. So we would have had to move this box down here. Here again, what we're doing is the new software eliminates blocks the, if you will, the artificial reverberation artifact so you don't see it. So now you can see where's a good place to do your measurements. Again, not having 3 parallel lines causes a lot of problem. You should never do this because these measurements are all inaccurate. Shadowing, and I'd like to show you here, again, you can see how bright the liver is here, but you'll notice here that this liver is also a little darker. So although it's obvious we have shadowing here, we still have some shadowing here. So again, no 3 parallel lines, bad reverberation. So we would not take any measurements in this box. Again, you can select if you want kPa or meters per second to show on the screen. You have an enormous number of options we don't have time to go through. This is page 1 of the report page. It does give you, again, all the measurements in kilopascals and in meters per second. And what's important is the median value and the IQR over median. So it provides you all the information you need to do your measurements. So to conclude, to obtain accurate liver stiffness measurements, adherence to a strict protocol is required. Both patient factors and scanning factors affect results. Now that there are excellent treatments for hepatitis B and C, and they're not that expensive, determination of liver stiffness values for treatment is not necessary. What is important is follow-up after treatment. NAFLD and NASH are major chronic liver disease now. With elevated liver stiffness values, the possibility of NASH should be considered. Determination of the fat content in the liver will be available soon using ultrasound and possibly also even inflammation in the next year or so. And following the delta change of patients is the most effective method for determining prognosis of progression or regression of disease. So with that, I'm going to end and turn it back over so we can find out what questions, if I can get my little pointer to the right spot.
No, that's okay. Thank you, Dr. Barr, and congratulations on such a great lecture. I'll be asking you to stop sharing your screen just for 2 minutes so I can bring some quick message in Portuguese. Then afterwards, we'll get back to you for the Q&As, okay?
Great. And I think I stopped sharing my screen.
Yes, yes,
Okay.
That's okay. Bom, boa tarde a todos. Meu nome é Diego Maia, eu sou gerente de produtos em ultrassom aqui na Philips. Eu queria passar um recadinho rápido para vocês. O primeiro deles é, desculpa. O primeiro deles é visite a nossa página, visite a página do evento. Lá tem uma série de informações a respeito das próximas aulas, das aulas que já se passaram, dos palestrantes e todos os temas que a gente abordou e ainda vai abordar. Tem informações também a respeito do nosso portfólio de produto, não somente de ultrassom, mas também de outras linhas aí da área de imagem. Com esse QR Code, você consegue ir direto para a página da Philips. E se você preferir também, pode ser através do www.philips.com.br/healthcare. Tá? Então, passa lá, dá uma olhada em tudo que a gente tem lá, tudo que a gente preparou para vocês. Um outro recado também se você tiver qualquer dúvida, quiser falar com a nossa equipe comercial, através desse QR Code também, já vai abrir o WhatsApp, salva aí o WhatsApp da Philips, e você pode entrar em contato com a gente, mandar uma mensagem, dizer de onde que você é e tudo mais, e a equipe comercial vai entrar em contato com você bem rapidinho aí para começar uma conversa e tirar toda e qualquer dúvida que você tiver a respeito dos nossos produtos, das nossas soluções e também das condições que a gente tem aí para oferecer. Bom, sobre isso temos algumas coisas que a gente preparou, algumas condições especiais. Uma delas é da parte de pagamento, se você está no momento aí de investimento. Alguns tiveram que interromper os investimentos, né, em função do Covid-19. Enfim, a gente preparou algumas condições. Uma delas é uma carência de até 180 dias. Você tem até 6 meses aí para pagar a sua primeira parcela, caso seja um momento pertinente aí para você investir em algum equipamento de ultrassom ou qualquer outro equipamento. Dos nossos produtos, a gente está com uma linha aí de 2 a 3 anos de garantia. Então, toda a nossa linha de equipamentos, inclusive a Affinity 70 e Epic, que são os equipamentos que a gente tem disponível aí, os recursos de elastografia que acabou de ser apresentado. Último recadinho, como um presente para você também, é uma forma de agradecer por estar participando do nosso evento, estar com a gente prestigiando esse evento da Philips. A gente está oferecendo para vocês aí um descontinho em alguns produtos da linha de saúde pessoal. Então, com esse código aí, Philips20OFF, você consegue ir lá na nossa página, dar uma olhada em alguns produtos que estão disponíveis lá com desconto de 20%. O recado era esse. Vamos voltar aí agora para as perguntas e respostas. Muito obrigado a todos e uma boa tarde. Boa noite.
Olá, boa noite a todos. Sou Rafaela, gerente de produto América Latina de ultrassom para radiologia. Vou ajudar aqui com as perguntas, mas antes só queria avisar que a gente, logo depois das perguntas, vai seguir com mais 25 minutos de aula aí do Dr. Barr para a parte de elastografia de mama, ok? Então, eu vou só ler uma pergunta que fizeram aqui no Q&A, já foi respondida por ele, só para que todos vejam. Dr. Barr, just read the question you already answered, ok? For everyone.
Okay.
Ok. Perguntaram se no protocolo dele, quantos dias ele usava de abstinência de álcool, quantos dias ele pedia de abstinência de álcool para os pacientes. Ele respondeu que precisava de 30 dias de abstinência. Vou ler agora as outras perguntas aqui em inglês. So, the first question. The severity of steatosis is a significant determinant of liver stiffness. Is there a way we can correct values determined by elastography for steatosis severity?
So, actually, I do not believe steatosis actually changes the liver stiffness value. It becomes very hard to get good measurements because of the attenuation of the RFE pulse. Within the next year or so, we will have ultrasound methods of actually quantifying the degree of fat in the liver. And again, it's these patients that have the steatotic livers that it becomes very hard to get good liver stiffness measurements.
Okay, thank you. We have another question about spleen. Don't you think that 17 kPa is too low for CSPH worst if you do not use the spleen stiffness together?
So what we like to say is if you have compensated advanced chronic liver disease, so above 13 kilopascals, then you should also do the spleen stiffness.
Okay, thank you.
Because if the probability of having a significant portal hypertension is not very high until you get to 13 kPa. So there's no use of doing spleen stiffness values below that value. So we're saying 17, if you have 17, you definitely have compensated advanced chronic, clinically significant portal hypertension, but some people may have a lower stiffness value and still have portal hypertension.
Okay, thanks. Obrigada a todos pela pergunta, obrigada Dr. Matteoni e Dr. Márcio Brandão pelas perguntas. Vamos seguir com o próximo tema. Dr. Barr, we're gonna follow with the next topic, okay? Just a quick video, 1 minute video, and
Okay.
then we go to the topic. Thank you. Oh, so I think we're going to start now, and then we pass the video, if you don't mind. Sorry.
Okay, so I will go ahead and share my
Are you
screen.
ready?
Yes.
Ok, thank you. Então vamos começar agora a próxima parte já. Só um minuto que o Dr. Barr vai projetar a tela dele.
So now we'll move on to using elastography in breast. And I'd like to just go over how we incorporate it into our clinical practice. So I'd like to review the results of strain and shear wave imaging of the breast, discuss interpretation of strain and shear wave in breast, and discuss the limitations of the technique, and learn how to incorporate strain and shear wave into your practice. The strain elastogram generates the relative stiffness of tissues in the image. Therefore, you may get a different value or shade of color depending on what other tissues are in your field of view. The technique to get optimal images is really different for each vendor. Some require no or little compression, like the Philips, while others may require you to manually compress and release the tissue. So in the Philips, you actually do nothing, do not move the probe. It would be the same technique as if you're doing shear wave. And one interesting feature, and although strain is not quantitative, there's a very unique feature that happens in breast. Malignant breast lesions appear larger in strain elastography, and benign lesions appear smaller. No one has been able to explain to me why this happens, but it happens, and it is a very sensitive and specific method of characterizing breast lesions. So we use the elastography to beam mode distance ratio when we characterize these. And here are images that you can see. On the left, an invasive ductal cancer goes from 6 millimeters to 8 millimeters, and a fibroadenoma on the right goes from 10 millimeters to 8 millimeters. So enlarging when it's a cancer, getting smaller when it's benign. We did a large multi-center trial using this technique with 635 patients. About 2/3 were benign and 1/3 were malignant. We had a large range of pathologies. This table shows you how we've done this. This is the site. N is the number of patients that they did. B is benign on pathology. M is malignant on pathology. B less than 1 is the E to B ratio is less than 1. M greater than 1, the E to B ratio is equal to or greater than 1. You'll notice that the sensitivity of 5 of the 6 sites was 100%, and 1 site was a 97%. So overall, 99% sensitivity. The 3 misses in this site actually were cases of DCIS and invasive lobular cancer, where we think the lesion on B mode was not measured properly. So that is one of the limiting factors in using this technique, is you have to be able to measure the lesion good in B mode as well as in elastography. If we look at the benign lesions, you can see the specificity ranged from 67 to 95%, an overall 87%, which is quite good. Now, I will tell you that this study was done before we really understood pre-compression that we're going to talk about, and I think that was the reason why there's such variability between sites in this study. But again, overall, this technique is very robust. Another interesting feature that occurs with the Philips machine is something I call the bullseye artifact. And it is cystic lesions. Benign cystic lesions show a black outer rim, a white inner dot, and a white distal dot. And we need all of these components to be able to call this. And we've seen this artifact in what we thought were simple cysts, complicated cysts, as well as some solid masses. We did a study, and whenever we see this, we biopsied those lesions, and they were all benign, simple or complicated cysts. So we had 100% sensitivity and specificity for using this sign to characterize a lesion as benign cystic. Now, you have to use EI setting 2 on the Philips machine to be able to do that. Another method that you can use to characterize strain imaging is the 5-point color scale. A scale of 1, the lesion is soft. 2, the lesion has mixed soft and hard components. 3, the lesion is stiff and appears smaller than on B mode. 4, the lesion is stiff and appears equal in size to B mode. And 5, the lesion is stiff and appears larger than in B mode. And in other vendors, not in the Philips, but in some other vendors, you may see this BGR or blue, green, red layering effect in CIS. Third method of evaluating strain images is the strain ratio. So in order to semi-quantitate strain data, the ratio of the lesion to background tissue, which we're always going to use fat for breast, can give an estimate of the stiffness of the value. So in this case, we use a color map with blue is stiff, red is soft. We put our A circle in the lesion and our B circle in fat, and we found that the lesion is 8.6 times stiffer than fat, and our results, we use a cutoff value of 4.5 between benign and malignant. So if we looked at this at the E to B ratio, it's obviously greater than 1. If we looked at the 5-point color scale, this would be a 5, and in the strain ratio, greater than 4.5. So all three methods would have characterized this lesion as a malignancy. We recently published in the Journal of Ultrasound in Medicine the results of a meta-analysis where we looked in the literature at all the published strain results, and we broke them up into the E to B method, the 5-point color method, and the strain ratio. And you can see that the sensitivity and specificity of the E to B distance ratio was the highest. And I think what's more important, if we look at the negative likelihood ratio, or LRN, of 0.3, statistically that's telling us that if we have a pre-test probability of 50%, all BI-RADS 4B or less lesions, we can downgrade them to a BI-RADS category 3. In the other two methods, the negative likelihood ratio is higher, and we can downgrade all 4A lesions, but we can't downgrade all 4B lesions. This is a video of a mucinous cancer. I showed this for two reasons. One is you can see that the lesion is not very conspicuous on B mode, but we can see it very well on strain. And the reason is that the stiffness of this lesion is markedly different than the background tissue, but the acoustical properties of this cancer are the same as the background tissue. And the reverse is also true, usually with benign lesions. So benign lesions such as fibrocystic disease, fibroadenomas, they have the same stiffness as glandular tissue. So if they're present in glandular tissue when we do strain imaging, they tend to blend into the background. The figure on the right is our published data where we looked at that E to B ratio for different grades of cancer. So you can see that the less aggressive cancers, mucinous comedo cancers, DCIS, always have a slower ratio. And we have had ratios of some mucinous cancers having a ratio of 1, as in this case. So we always biopsy if we have a ratio of 1. And you can see as the grade of the cancers gets higher in the invasive ductal cancers, the length ratio actually increases statistically. The lobulars tend to be all over the place. And again, we think that's partly because we do such a bad job in measuring the size in B mode. Shear wave imaging, again, similar to we did liver. Push pulse is used to generate shear waves perpendicular to the push pulse. We measure the shear wave speed, and again, it's with conventional B mode ultrasound, so we must have a good B mode image to do this. The shear wave speed is proportional to the stiffness of the tissue. The stiffer the tissue, the faster the shear wave. And again, we can either do point shear wave or 2D, as we talked about in liver. However, when you're looking at cancers or focal lesions, malignant lesions are always very heterogeneous in stiffness. So you need to know where to place your ROI box to find the stiffest area to get a good interpretation. So we can't use point shear wave because we don't have that color map to tell us where the highest value is. So in breast, we're always going to use 2D shear wave, look at that color map and find the area of highest stiffness within the lesion or the surrounding 3 millimeter area. And here are some examples. On the right, we have a benign lesions that are fibroadenomas. Again, you can see the velocity map. The lesions are pretty uniform. Our quality map is green. It's very good. We've got some areas of bad data near the top. But here in this invasive ductal cancer, notice that there are areas that are very soft and areas that are very stiff and others that are intermediate. And we interpret the shear wave by finding this area of the stiffest area within the lesion or within approximately 3 millimeter surrounding rim. And we'll talk about why that is shortly. When we're doing breast elastography or any small parts lesion, what's really critical is the amount of pressure that you apply with the transducer. And I call that pre-compression. Some people call it preload. So when you compress something, you actually make it stiffer. So in the liver, we're scanning between the ribs. No matter how hard you push, you're really not going to apply pressure to the liver because the ribs are going to prevent you from doing that. And that's one of the reasons why we don't have you do substernal scanning, because you can put pressure on the liver and it's very hard for you to get the liver capsule perpendicular to the transducer. And this is a study that we published some time ago where we looked at all the different tissues that we could find or pathologies that we can find in breast. And you'll notice this is increasing pressure. So I'm putting pressure with the transducer. I'm pushing on the transducer. And you'll notice that the shear wave speeds all increase as I increase the pressure. And benign lesions will eventually become as stiff as cancers if you apply enough pressure. And you'll notice that if you're using cutoff values, depending on the amount of pressure you put, your cutoff values are going to be different. With strain elastography, what we're really worried about is the distance between these, right? We're looking at the relative stiffness. So again, you can see that that stiffness is much higher down here with light touch, if you will. It's very small up here. And if we did our strain elastography in this area, all we would get is noise. We would not be able to measure accurate shear wave speeds. So in this paper, we also did what we use now to control and understand how much pre-compression we're applying. So we pick an object. So here, if we're starting, we like to apply some pressure with B mode. It flattens out the Cooper's ligament so you eliminate some artifacts. So here, this rib is at 3 centimeters deep. I've done my B mode image and I'm happy with that. Now I'm going to move on to doing my elastography. So now I'm going to lift up the probe, just lightly lift up the probe. And as I do that, we're going to release that tension and the rib is going to fall here to 4 centimeters. And if I remove any more pressure, I would lose contact. So I'm just have a very light contact. And again, this is also a very good place to do your color Doppler or power Doppler or MFI, because again, as you compress, you're compressing the blood vessels also, and you'll get much better color if you use this technique. Then you're doing your color Doppler and elastography here, doing your B mode imaging here. This is just clinically to show you what happens. This is a benign cyst done properly. You'll notice that we've got all nice low values, blue. And if you look at, here's the rib, the rib, the rib, the rib. So you can see I'm pushing down with the transducer and I'm narrowing that space between the rib and the transducer. And I can take this benign cyst and I can turn it into a beautiful cancer by applying pressure. So it's very important that you're doing your measurements at this level and not at other levels, because you can get obviously bad results. The cutoff values we use for the Phillips system for benign lesions for shear wave, less than 4.5 meters per second or 60 kilopascals benign. Malignant, greater than 4.5 meters per second or 60 kilopascals for malignant. We already went over the strain. E to B ratio is of equal to or greater than 1 is malignant, and an E to B ratio of less than 1 is benign. And I want you to remember that each vendor may have different values. They calculate strain differently. And this is really critical for strain ratio, because the strain ratios that you will get for various vendors will be significantly different. In our experience, the shear wave speeds are a little bit more the same between vendors. But one key thing here is that there's an artifact in shear wave imaging that the cutoff values could be very wrong. There's something called blue or soft cancers, meaning that on shear wave, their values are very low, but they're actually cancers. And we're going to talk about that in detail. And in our experience with a light touch, approximately 50% of invasive ductal cancers will either code as soft or have no signal with shear wave imaging. Many of them will have a ring of high shear wave speed surrounding the tumor. And this is why we want you to take the measurements, the highest value, either in the tumor or surrounding ring, which usually is about 3 millimeters. And if you realize that kind of corresponds to strain, where the lesions appear larger on strain and when they're cancers. So this is an example of one of these softer blue cancers. This happens on every vendor. Here's the lesion. The stiffest area is actually on the outside, but it's very soft. And the cancer itself is very soft, about 15 kilopascals. But if we look at strain, our strain ratio, or E to B ratio, is 1.9, highly suggestive of a malignancy. So here, shear wave suggests benign, strain suggests malignancy. And again, we've looked at this in great detail. Every vendor on this tumor had shear wave as being below the cutoff values, suggesting it was a benign lesion. Every vendor had a E to B ratio of greater than 1, suggesting it's a malignant lesion. So this is not a vendor-specific problem. This is really a histology problem. And we worked at this. On my system, I'm allowed to see the displacement curves or watch how the shear waves are tracked. And what you can see in this blue cancer, this is the cancer, but it has a ring of red around it. In the cancer itself, the shear wave are all noise. In the area where we're getting these higher measurements, we are getting these displacement curves. This is showing the shear waves going through at different points of time at different locations. And from this is what we calculate the shear wave speed. So when we recognize this, this is when we worked with vendors to develop what we call the quality or confidence map, which green is go, yellow is caution, red is stop. And the reason this happens is we look at, are the shear waves high enough? Do they have a really good intensity that we can measure them? Is there noise? Is the curve that we draw a straight line to calculate the shear wave speed, or is there error there? And we combine all these into a numerical value from 0 to 100. And again, this is the same map that we're using in the liver. And again, we want to take measurements where they're green. Here I actually took it where it's yellow. This is another malignancy. You can see over here, and here the stiffness value that is the highest is actually in the tumor. And even though it's yellow, I went ahead and did our measurements. So again, we have strain and shear wave on the EPIC system, and we really like to do both because the problems that we have with strain, which are usually benign lesions surrounded by glandular tissue, are easy to identify on shear wave, and those blue cancers on shear wave are easy to define on strain. So the problems of one are solved by the other, and doing both really can increase our diagnostic confidence and accuracy. We always have some false positives, and these include fat necrosis and mastitis. The reason, they have associated inflammation, swelling around them, and just as in the liver that has inflammation, they appear stiffer. And we notice a small percentage of fibroadenomas and sclerotic lesions will also give you false positive, maybe on the order of about 5%. All our false negatives have been lymphoma, which actually is soft. Ours have been very well circumscribed, very hypoechoic lesions with marked blood flow. So when we have those lesions, we don't believe elastography, especially if the patient has lymphoma. And obviously, when there are conflicting results, you should always err on the side of biopsy. Just some quick clinical cases as we're running out of time. This patient came in, was a 40-some-year-old lady that had palpable mass. She had been seen somewhere else. They couldn't find anything wrong. They sent her to us. Here's our B mode image. And here you can see nothing of interest, but we put the transducer over that area. We do our elastography, and we get a perfect bullseye artifact. So this turned out to be a complicated cyst. So we stuck a needle in and aspirated it. It went away, and the palpable mass went away. This is a lesion that I learned the most, new lesion on mammography. We try to do all our biopsies on ultrasound. I like to say this lesion had a body, a tail with a green arrow, and a head circled in red. When we do our strain elastography, the body and tail get larger, the head disappeared. So this patient we did a biopsy, it was invasive ductal cancer. She had her lumpectomy. I asked the pathologist to pull out the slides, and the head actually was a benign fibroadenoma. So the elastography correctly predicted that this was benign and this was malignant. So we like to use this even in BI-RADS 5 lesions because we've now seen several cases where there's a benign lesion next to a malignant lesion, and we think they're one lesion on B mode. So we use this to guide our biopsies, and we biopsy the stiffest area to get the best radiology pathology correlation. An elderly lady with a bloody discharge, she had this bilobe mass. One side is extremely soft, one side is extremely stiff. This turned out to be a hematoma. We don't get the bullseye artifact because the hematoma is got enough viscosity, it's thick. It doesn't allow the bullseye artifact to occur. So we stuck a needle in here and aspirated old blood. We biopsied this with a cord needle, and this turned out to be an invasive papillary carcinoma. We were always concerned with the bullseye artifact that we would miss cystic renal masses versus complicated cysts. And this is actually from the multi-center trial. This is a 2-millimeter papilloma. So you can see you can get great imaging if you have good technique. And you'll notice that we have the bullseye from the cystic part, but this solid component shows up as a solid component. So using this technique, we can distinguish complicated cysts where everything is moving inside and there's nothing fixed, gives us a perfect bullseye, versus a complicated cystic mass where the non-moving part doesn't mean that it's a malignancy, it's just that it's not moving will show up as a defect. So this raises our suspicion that we need to do additional either follow-up or biopsy of these lesions. Again, this is what I like to show as an example of the problems you're going to have with strain. Hypoechoic lesion surrounded by glandular tissue. Hypoechoic lesion surrounded by glandular tissue. Here, we don't really see the lesion at all. It blends in with the background tissue and is a benign with fibrocystic disease. Where here, the benign lesion is clearly identified as being larger. The glandular tissue is now a light gray and fat is white. So I'm using white as soft and black as stiff here. So you can see that this becomes the problem. This could have easily been a blue cancer on shear wave. So strain would have flagged to us, it's a cancer. Here, you don't have very much confidence because you don't see the lesion. This would have been very easy to have a shear wave image. You would not have any artifacts, it would be very simple. Again, this is our false negatives. This is one example of a lymphoma. It's soft on both strain and shear wave as it is a soft lesion. Again, they tended to be in our series, all well circumscribed, very hypoechoic lesions with a lot of blood flow. A false positive, again, fat necrosis and mastitis OR2 that we see quite often when we do this. So how do I incorporate strain and shear wave into my practice? So if both strain and shear wave are suggestive of a benign lesion, I have very high confidence the lesion is benign. The only false negatives that we are aware of is lymphoma. And if we do see a well-circumscribed, very hypoechoic lesion with marked internal blood flow, and particularly if the patient has a history of lymphoma, we would biopsy it, even though elastography is negative, but otherwise we would not biopsy this lesion. Both strain and shear wave are suggestive of a malignant lesion. we have very high confidence the lesion is malignant. Again, our false positives are mastitis, fat necrosis, and a few fibroadenomas. So clinically, if the patient has mastitis, we consider treatment and short-term interval follow-up. If the mammogram is calcifications suggestive of fat necrosis, or we know that patient had a biopsy there and our suspicion is low, we would consider a short-term interval follow-up, even though the elastography is suggestive of a malignancy. If strain is positive and shear wave is negative, again, we check the quality of the shear wave. If it's poor, obviously, then it's going to be malignant. So all of these blue cancers will have, or the vast majority of them will have, a very poor quality map flagging to you not to believe the data. And in general, all these lesions will be malignant, so we biopsy them. If strain is negative and shear wave is positive, which I don't have very many cases of, consider that you added too much pressure when you're doing the shear wave elastography, and the value of fat should be about 1.2 meters per second. But obviously, if it still comes back after you release some pressure, malignant lesion, you should biopsy it. Now, I will tell you that it's really easy to do both on the EPIC because the technique is identical. There is no learning curve for strain imaging. It's the same as shear wave imaging. You just hold the probe still. You want to try to be perpendicular to the lesion. You let the patient's breathing do the really motion, and you just can flip from shear wave to elastography strain by just pushing the buttons. You don't have to move the transducer, and you can get excellent images by doing that. So with under a minute, you can do both of these very easily, see the results, and be able to tell the patient a conclusion of what you think. So both strain and shear wave provide additional information on breast lesion characterization. Technique is critical, always done in conjunction with B mode. I didn't mention BI-RADS a lot, but obviously in those higher BI-RADS of 4C and a 5, we would probably always biopsy the lesion. But I think it's important to do elastography because if you biopsied a BI-RADS 5 lesion and the pathologist gave you a benign diagnosis and the elastography was suggestive of a benign lesion, I would feel very comfortable that I don't need to do anything else. Whereas if it was a BI-RADS 5 and the pathology came back as benign and strain and shear wave were suggestive of a malignant lesion, then I would say we missed the lesion or something doesn't make sense. We need to do additional work. So even we really do this elastography on every case because we find it very helpful. Strain in our hands has the highest sensitivity because we have those blue cancers in shear wave. Shear wave has the highest specificity because benign lesions are very difficult when they're surrounded by glandular tissue to get a good strain image. So, and there's significant improvement in the sensitivity of shear wave with the addition of the quality measure or confidence map. And again, the combination of strain and shear wave really increases our confidence and accuracy. So with that, I'm going to end and ask if you have any questions.
Thank you, Dr. Barr. I will follow up with 2 questions while people can type in the chat. So, então, pessoal, vou seguir aqui com 2 perguntas que eu já recebi. Se tiverem mais alguma pergunta, por favor, podem escrever no chat ou na sessão de Q&A. So, first question. What's the correlation? It's a more generic question. What's the correlation between the shear wave and the point shear wave cutoff values, if there is one? And can you use the same tables?
Yes, so we never do point shear wave in breast. And the reason is that, in fact, we don't do it in any focal lesion because cancers are very heterogeneous in stiffness. Some areas are very stiff. Some areas may be very soft because of necrosis. When you do point shear wave, you don't know where to take your measurement. So unless you're going to take many, many measurements over the whole area to find the stiffest area, which is very difficult to do, you're going to get poor results. The 2D we always use because we have the big field of view and we can see the variability and stiffness of the lesion, find the stiffest area to do our measurement. The cutoff values would be the same for point shear wave and for 2D shear wave, but it's very, very difficult to find that stiffest area accurately when you only have point shear wave.
Okay, thank you. And just following up, for other anatomies like liver, is there a correlation that we can use? Can use the same table?
So, well, for liver lesion, the cutoff values are going to be different for every organ. For liver, the problem is that there are stiff hemangiomas and soft hemangiomas. There are stiff HCCs and there are soft HCCs. So in general, yes, malignant lesions are stiffer and benign lesions are softer, but in any given lesion, you can't really tell with confidence, high confidence, if the lesion is benign or malignant. So we usually do not use elastography to characterize focal liver lesions. We use ultrasound contrast, and I know it's approved in Brazil. I don't know how many people are using it, but we find that to be much more helpful than elastography for focal liver lesions. For thyroid lesions, it's very difficult because the cutoff values seem to vary a lot between the different studies. Some people like to use the ratio, the strain ratio of the lesion versus normal glandular tissue. If you can do that in a ratio above 2.5, is suggestive of a malignant lesion. We get beautiful images with both strain and shear wave of the thyroid, but I have had several papillary cancers that are very soft and are the same stiffness as glandular tissue. So in breast, I cancel biopsies all the time if the shear wave suggests it's benign, but I'm afraid to do that in thyroid because we've had so many soft thyroid cancers. So in thyroid, I tend to use the value if it's high and I'm not so suspicious, then I would do an extra biopsy. So in thyroid, I tend to do more biopsies because of shear wave. In breast, I do less. Other organs, we're still learning, so it's very hard to give cutoff values. I would recommend that they look at the WFM guidelines for elastography for non-hepatic uses, which was published several years ago. It actually goes through the literature on all the different organs and gives you what is the most appropriate way to use to evaluate that.